my name is Alice Liu. I'm the co-host of Aging Well, and today we have Dr. Stephen Cramer with us today. He is a stroke neurologist at the University of California, Los Angeles. He's the medical director of research at California Rehabilitation Institute and holds the Susan and David Wilstein Endowed Chair in Rehabilitation Medicine. He focuses on neural repair after CNS injury in humans with an emphasis on stroke and the recovery of movement. So, Dr. Kramer, how are you today?
I'm good, thanks. How are you?
I'm great. Thank you for asking. So, to dive right into it, I just want to ask you in your own words to tell us about your research and your current projects.
You bet. So I'm a stroke neurologist, also an internist, and in my lab, we ask the question, when a person has a stroke and some people get better, why do some people get better more and some people get better less? What's going on with that? And what can we throw at that medically? Zap, inject, cells, whatever, in order to get the best outcomes for everybody. And what can we measure in the brain? What biomarker can we collect in order to get insight into what's going on in there? So it's all about neural repair with a focus on stroke.
And what techniques do you use to look into this?
Yeah, well, the brain does not reveal its secrets easily. So we use lots of techniques. Number one is always behavior. It's where it starts and ends. And so we do detailed behavioral phenotyping, meaning that we look as many angles as we can. Movement, sensation, memory, mood, all of these things interact and are important clues to what's going on. But you have to take a peek under the hood when you want to understand what's going on with the brain. So we do a lot of MRI scanning as well, both structural scanning to see what's there, how it's looking, how intact it is, where's the hole. Also functional scanning, which is a kind of newer concept to see the circuit firing away and talking to each other. We also do EEG. We put 256 little microphones on the scalp and listen to all the electrical conversations in the brain and work with smart engineers and programmers who tell us how to reduce that to circuit function and circuit interaction. We do other things as well, such as transcranial magnetic stimulation to look at physiology and genetics. We're all born with different genetics that can teach us so much about differences between people and how the brain works. You are not your genes, but they are a big stripe that makes you who you are.
Wow, sounds like there's a lot going on over here. Is there anything that you're more particularly focused on or
Yeah.
interested in?
So as I become a senior professor, whatever, I'm trying to come up with things that are not only useful, but are really broadly useful. And so I'd say two of the things we're doing in the lab might have broader implications. We've been doing some telehealth research, telehealth to give people extra doses of rehab care. And also, I'd like to see the EEG program develop into a biomarker that we could all check. So, for example, if somebody has chest pain, the first thing most clinicians would do is do an EKG, put some stickers on the chest and see if it looks like a heart attack or not. It's very helpful. I wonder if in the future, if we were worried about somebody having a stroke, if we could put some stickers on the head and pull out the same kind of information. Or if somebody has a stroke and we want to do a rehab, if we could put stickers on the head and ask specific questions about how much rehab we should do and when we should start it, and this kind of thing. So telehealth and EEG, I think, may have broad implications as I go through this phase of my research career.
Wow, fascinating. Would you say that those have the most potential then in the recent future?
Well, I'm leaning into them, so I must think there's something there.
That's so great. I also hear that you're involved with NIH Stroke Net. So what do you do there? Could you tell me about that?
You bet. Um, what became apparent over the last decade or two was that some clinical questions, some trials require quite a village. And so if you have everybody out there doing their own thing in order to ask questions about what's the next best therapy, it's inefficient and it's costly. Um, and so what NIH did, NIH being National Institutes of Health, funds so much of the research in the United States. What they said was, let's come up with a clinical trial network, and we'll have some central resource, and then anybody who wants to do a trial can work within the network. So StrokeNet is the stroke clinical trial network. I'm the co-PI of that, and I'm in charge of the recovery and rehab branch of things. And so if somebody wants to do a stroke trial and it involves after the injury, the recovery phase or rehab type therapies, I help the investigators get through the many stages of network application, but also together with my co-chair, Steve Wolf, we help them boost up the quality of the study. And so basically administrative stuff, moving recovery and rehab stroke trials through NIH network.
Wow, that's amazing. Something that the audience might be curious to know more about is, are there any key points that we should know in regard to rehabilitation after a stroke? Like some advice or tips?
Oh, yeah. I'll try to be helpful, but there's a lot of thoughts there. Um, so for one thing, um, uh, there's the usual medical stuff. And so if somebody has a stroke, you want to have a good medical care. If a person has urinary infection or pneumonia or fall early after stroke, that's going to make it harder to get back on their feet, right? And then good rehabilitation care, which involves a team, is very important. And in America, I should say in USA, forgive me, many people don't get very high doses of rehab care. It may be different in Canada, but insurers and providers often come in, I think, a little shy of what the person needs. So advocate for top-notch care. High doses. If you're not tired at the end of rehab, you didn't do it enough. Every day for weeks and weeks and weeks and weeks. It's not the time to be comfortable or to crawl under a rock because you really want to get that brain rewired. But we're social creatures. And so all the good medicines and all the good rehab care are only parts of the puzzle. There's also psychosocial aspects. And sometimes I say it takes a village to get better from stroke. And people who are lonely or isolated are going to have a harder time. So in any way possible, lean into social networks, whether it's your friends, your loved ones, um, your neighbor's sister's nephew who lives around the block, or an online forum. We're social creatures, and it's a big part of getting better from stroke, as are psychological issues. Maybe a third of people have depression by a year post-stroke, and maybe a quarter have a significant anxiety disorder. And it's not hard to understand after such a life-changing event. Getting proper attention for those things can have an impact on how well one recovers in a broader sense. So there's lots of pillars to good recovery, some traditional and some things that we don't often think about, but are probably just as important.
Yes, I can completely understand that, especially the psychosocial aspect, as you were saying. I was curious if you had any tips about preventing stroke in the first place.
I'm a vascular neurologist, so I think about these things as well. And I should say that having another stroke is one of the worst things for getting better from the first stroke. So it's both important to keep stroke out of one's life and as a tool to maximize recovery should a stroke occur. Um, for most people, there are a standard set of risk factors that we know about. And if they work with their primary care doc, they can identify the presence of those risk factors and try to optimize them, control them, get them in the good range. And this can significantly reduce the risk of stroke at many levels to a large degree. The most common risk factor and the one that needs the most attention is high blood pressure. We call it hypertension, but it's not really a matter of stress or anxiety. It just means that the pressure in your pipes is too high. And by the time somebody's in their older years, maybe a third of people have this, maybe more. And at least in some countries, Western countries, half of people either don't know they have it or it's not under control. That's a spectacularly high fail rate. That means people aren't going to their doctor, or docs aren't checking, or people aren't taking their pills when they're given them. It's a combination of things, and it depends on the person. So the number one most important recommendation to keep stroke and heart attack out of your life is to get your blood pressure checked. And if it's high, we call 130 over 80 the cutoff for most people. If it's high, get medicine and work with a professional to get the blood pressure down. That's the 10 most important things I have to say. Really important. There are other things, and I'll run through them as well. Some people, the heart goes into an irregular electrical rhythm. Instead of thump, 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 it's more of a pitter patter. And it's called atrial fibrillation. Atria is the part of the heart where it happens, and fibrillation is just how the muscle isn't what it's doing when it's not pumping right. And that can make clots that get thrown to the brain. And blood thinners can prevent the vast majority of those strokes. But you have to have somebody listen to your heart or do an EKG. An EKG on your smartphone now, so highly preventable. And then things like diabetes and high cholesterol, these are not uncommon, and good medical care can prevent some complications. Um, Being overweight, not exercising, some lifestyle things. It's hard to get people to change what they do every day, but if a person is highly overweight and loses a bunch of pounds, that's good for preventing stroke. If a person does not exercise and starts exercising, that's really good for preventing stroke and heart attacks. And by the way, exercise doesn't necessarily mean going to the gym and lifting 500 pounds or whatever. Just go for a walk every day. Get a little sweat. Just go for 20, 30 minutes at first. And that can help with the heart. The last thing I'll say is diet. The American Heart Association has the DASH diet and the Mediterranean diet, which many of us have heard of. A diet rich in fruits and vegetables and fish and poultry that avoids many fats and fried foods, red meat and dairy. Now, it doesn't mean you can't have a little fun now and then, a scoop of ice cream in the summer, but a healthy diet can go a long way towards healthier, longer lifetime.
Thank you so much for sharing all of those tips. You mentioned some things about lifestyle. I'm a little bit curious, is there anything you do personally to help with prevention as well?
Oh, happy to share. First thing I do when I wake up is I meditate for 10 minutes. I have my favorite app and listen to my thoughts and work with my thoughts and try to understand what's going on and be in control of them. Next thing I do is I eat organic fruits. Organic because pesticides are common in American food, US food, and they're not good for you. So organic fruits and nuts, smoothie breakfast. I exercise for 40 minutes. I pump on that bicycle as hard as I can while listening to my music and reading my medical journals because I hate exercise. I hate sweaty mammals, the whole thing. So I just do it and get it done with, but every day. And then lunch is organic vegetable salad with nuts. Try and eat healthy. And dinner is usually poultry or fish. Um, and then I check my blood pressure every week. I have a little Omron. Can I say the name of the brand? Home blood pressure kit, and always making sure my blood pressure is under control. Because I've seen what happens when people have pressure that's high and they don't do anything about it. Personally, um, I have a wife and two kids, and that is my main thing in life. I also play French horn in at the LA Orchestra Nova, and that's wonderful. Um, the thing I like most about playing in an orchestra is when you're successful, you're imperceptible. You're salient, you failed. And so we all work together as one team, one sound, and that's really fun. Also, music is different from just reading neurology all day. So I like to play French horn and guitar and just that's probably my main avocation.
Seems like you're much of a team player, especially like also in the lab and all.
Try.
A stroke today, and it does bring a little bit of fear. So I was wondering if you could maybe talk about some more positive things related to stroke, like after you get one or after something happens and that happens, is there something like, oh, okay, well, you can be rehabilitated and be just fine after that, or if you have a better diet, etc.
Right. So of course we want to prevent it. And if an acute stroke happens, we want a person to go to an acute care hospital and do everything we can to reverse it. But if a stroke deficits persist, we want to rehab as much as we can. And most people get most of it back after a stroke. It's not the end of the world. But even if a person has enduring disability, life goes on. Most people are still glad to be alive after a stroke. They can still put their grandkid on their knee or join in at bingo or go for walks, hobbles in the park. But life goes on, and most people with good medical care, good rehab care, can still enjoy life, even if the body or parts of the mind are different.
Well, we've had a really big talk today, so thank you so much, Dr. Kramer. It's been lovely talking with you today, and thank you so much for sharing the points that you did. I hope that the audience is able to learn something today.
Sure.
This
If
has
you're at
been
UCLA, come on by.
Yeah, that would be great. So this has been Alice, the co